Seattle Cancer Care Alliance. She's a radiation oncologist trained at Duke University and Johns Hopkins, and she's going to give us an update on radiation therapy. Jing.
Thank you. I'm excited here to spend a few minutes with you today to talk about radiation therapy and some of the topics that we are currently very excited about in terms of prostate cancer treatment. In case you're not familiar with radiation therapy, I was just going to talk a little bit about basics. So most of radiation treatments in the United States are basically given with these machines called linear accelerators. The radiation is being generated by a linear accelerator, for example, as you can see on the left-hand side of the screen. And there's no radioactive material anywhere in the machine or the room. The radiation is present only when the machine is on. And on the right side, it's basically an artistic depiction of what a beam would look like. The beam is invisible. You don't actually see anything coming out of the machine. But basically, the beam travels through the body and treats the area that we're trying to treat. This is, of course, different from brachytherapy, which is radioactive seed implants that's used in prostate cancer treatment quite often as well, where you actually are taking small radioactive seeds and implant it into the prostate. In that scenario, the man's prostate is radioactive, a little bit radioactive for a short period of time, but most radiation treatments in the United States are given in the form of external beam radiation with various kinds of machines. There's been a lot of evolution in technology for radiation treatment. The goal has always been to kill cancer cells and try not to kill too many of the normal cells that are in the way. In the good old days, kind of on the left-hand side, we did radiation kind of in the rectangular box form, which means you take an X-ray, you guess at where the prostate should be, you draw a rectangular box around that area, and then you give radiation beams. And so the three images are all basically an axial CT slice through the low pelvis. And the prostate is in the middle of the screen. There's a little bit of, you can see a rectum behind the prostate. You don't see the bladder, which sits above the prostate, and then you see the femurs on the two sides as well. But in the good old days, the radiation was more rectangular box shaped, so you treat the prostate, but you also treat a fair amount of normal tissue around the prostate. More recently, we've been moving towards something called IMRT, intensively modulated radiation therapy, which instead of using a rectangular box-shaped radiation, you have a lot of different beams coming from a lot of different directions that are all shaped like the area that you're trying to treat, so in this case, the prostate. And you're giving a still high dose to the prostate itself, but you start giving a lot less dose to the area around the prostate. In the more recent years, there's also been a lot of increasing availability of proton therapy in the United States as well. We also have a proton center here open in Seattle. And the major difference there is that the radiation beam goes into the body and it does not come out the other side. So it stops after a certain calculated distance. So it has the potential for further decreasing dose to normal tissue. I think in radiation oncology, as we become smaller and smaller with our radiation beam, you also need to be certain that you know then where your target is, because you don't want to miss the prostate as you're treating. And so it's also led to the evolution of IGRT. It stands for image-guided radiation therapy. All it's saying is, if you want to be precise, then you need to know where your target is. So for a long time, and we still do this as well, unfortunately, you can't see the prostate on an X-ray, but you can implant markers into the prostate so that you can see the markers on an X-ray. So that's what the top two images are showing, that there's 4 little markers that are implanted into the prostate. And there's been various levels of sophistication with this as well. And there are systems such as Calypso that have the ability to even allow tracking of these beacons, so that even as you're lying on the treatment table for a few minutes and there might be small amount of motion in the prostate, those beacons can track the motion. Besides X-rays, there's also been evolution in technology so that you can now do a daily very low dose CT scan called cone beam CT before you give the radiation treatment. So on a CT scan you can see the prostate itself much better than you can on an X-ray. We certainly do believe in validating the evolution of technology, and so our center, as well as many other centers, for example, proton therapy centers across the country, are participating in a randomized trial called PART-QL, Prostate Advanced Radiation Technologies Investigating Quality of Life, looking at a comparison of proton therapy versus IMRT for patients with prostate cancer. The trial was initially started by the Massachusetts General Hospital with the Harvard group in Boston, and we are participating in the trial as well. And basically, it's taking several hundred men who have prostate cancer, and they're being randomized to proton radiation versus IMRT, and looking at quality of life, actually, as the primary endpoint. Something that's a fairly recent development that actually has nothing to do with radiation, but we're very excited about it in the field of radiation oncology, is a new product called the Space OAR Hydrogel. And even as a radiation oncologist, I admit that the best way to avoid radiation side effects is to not give any radiation to that particular organ. And so, unfortunately, I think the quote was well said that, the prostate is in a tough location. It is right below your bladder. It is right in front of your rectum. And, of course, the urethra travels through it as well. And the Space OAR Hydrogel, basically, it's a very simple concept, but it works beautifully. It is a gel that you inject between the prostate and the rectum, and it pushes the rectum away from the prostate. So I see a lot of men, you probably all had rectal exams, you probably know that there's a patch of your rectum that's right behind your prostate, and no matter how precise we are with the radiation, you are always going to give some radiation to that patch of rectum. But with this, you can physically push away the rectum, and therefore you don't have to give it as much radiation. And so basically, the gel, again, it's placed between the rectum and the prostate, and this is a slice, kind of a zoomed in slice of an axial slice of what the anatomy relationship is between the prostate and the rectum. And basically, when we do radiation treatment, there's always going to be a little bit of high-dose radiation that exists for a few millimeters around the prostate itself, and unfortunately, the rectum is within that few millimeter margin, whereas when you inject the gel, which pushes away the rectum, now that rectum is no longer within the high-dose region, so you're going to drastically decrease the odds of some kind of side effect from the radiation treatment. The gel is supposed to stay in place perfectly for 3 months, and then it's absorbed by the system, and you pee it out before the 6-month mark. So this actually was tested in a randomized clinical trial of a few hundred patients. Half got radiation plus the gel, and what they were able to show is that, on the left-hand side, patient-reported incidence of rectal pain was much lower when you use the gel versus when you do not, and the rate of any kind of rectal toxicity was much lower at the 1-year mark when you use the gel versus when you do not. To kind of further, they did follow patients out for further as well. So at the 15-month mark, on the left-hand side, it's the control group who did not have the gel, just radiation treatment, and you have about about 1 out of 14 patients will have some kind of rectal toxicity. It can be as high as grade 3, meaning you have to intervene somehow for the side effect. Whereas when you use the gel, it's about 1 in 49 patients have any kind of bowel toxicity, and really most of them are pretty mild and transient and require no intervention. So we are very excited about the program, and we have started launching this and offering it to our patients starting this month, actually, in conjunction with our colleagues in urology. Another exciting development in the field of radiation oncology is something called Stereotactic body radiotherapy, or SBRT is the acronym that most people know it by. But basically, it's talking about using very focused radiation so that you're treating less normal tissue. So you can now give treatment in very few doses. Conventional treatment for prostate cancer radiation, it's usually given daily, Monday through Friday, over the course of about 8 to 9 weeks. With something like SBRT, you're usually talking about somewhere between 1 to 5 treatments, period. It's kind of like a very advanced form of IMRT. The picture is meant to depict that. It's showing the bony structure of the low pelvis as well as the prostate, and then the yellow is the rectum right behind it. And basically, you're just using a lot of radiation beams coming from different directions that all converge on what you're trying to treat so that you get a high dose around your target, but a much lower dose elsewhere. There are a lot of different machines from different companies that can do do this, but CyberKnife has probably been by far the most successful at advertising, so a lot of people have heard of CyberKnife. Gamma knife is another kind of word that a lot of people have heard of, but Gamma knife is specific for the brain, whereas CyberKnife can treat larger areas from head to toe. So not only has it been used for, curative treatment of prostate cancer, it's also starting to be used for oligo-metastatic prostate cancer, meaning, if you have prostate cancer and has spread, but it's only spread to a few spots, it's in some scenarios worth aggressive treatment to those spots as well, in addition to systemic therapy such as hormone therapy. And so usually these SBRT treatments, they're 1 to 5 outpatient treatments of about an hour long each. They're generally, depending on location, well tolerated with very high rates of local control. The image on the left is kind of showing the more traditional way of treating a prostate that may have spread to one of the vertebral bodies in the spine. This is a section across the chest, so there's the heart, there's the 2 lungs on the sides, and basically you're kind of seeing that it's a more rectangular box-shaped radiation where you have the vertebral body and you're just kind of aiming a rectangular box of radiation at it, whereas kind of with more sophisticated radiation, you can tailor the dose to more tightly conform to the vertebral body itself. So you can give a higher dose that's more effective over fewer treatments. We can do this for bone metastasis, but we can also certainly do this for lymph node involvement as well, which happens pretty commonly in prostate cancer. So these are 3 images of the same patient, an axial slice, a coronal slice, and a sagittal slice as well, and basically showing that you can focus radiation to a very small region. And this has also facilitated a re-irradiation, meaning perhaps you've had radiation previously to an area, but we need to give a second round to a smaller area inside that site because perhaps years have passed and there is now a recurrence in that region. In terms of looking towards the future, I think, radiation, we're looking forward to perhaps becoming more than just a local therapy, meaning that for a long time, radiation works where you point the beam, but it does not work where you do not point the beam. But we're excited about some of the recent developments, and I think we have a whole session dedicated to immunotherapy later, so I won't speak much about this. But radiation, you can use it to zap a tumor. It will cause, especially now that you can give very high doses like with SBRT, it will cause a lot of death in that tumor. It releases a whole bunch of, tumor proteins, antigens, and we think that this may be used as kind of a boost, like a vaccine, where your body and immune system will now see a flood of all of these tumor, proteins, and perhaps generate an immune response with it. Radiation by itself is not adequate for inducing the response, but in conjunction with some of the new immunotherapy agents that are out there, it can be kind of work in conjunction with each other. So this, for example, is a case report that was published a few years ago in a very prominent medical journal in New England Journal of Medicine. And this in particular is talking about a patient with metastatic melanoma, which is a cancer that's treated very often with various kinds of immunotherapy agents. But it's talking about something called the Abscopal effect, which is you zap one spot with radiation and you see response across multiple spots that are not treated. So what the images and the timeline on the bottom right are showing that this is a patient who had metastatic melanoma. They were placed on an immunotherapy agent called ipilimumab, which helps to basically, it's called a checkpoint inhibitor. It helps to activate the immune system so that it kind of starts to be active against cancer cells again. But initially, the patient received several doses of this medicine. His cancer, which had spread to, there was a small tumor kind of on the top. It's talking about small tumor next to the spine in the chest. There's also some lymph nodes in the chest that were involved. There was a spot in the liver and multiple spots in the spleen. And initially, the patient's tumors were all stable on this medicine, and then it started slowly growing on this medicine. Finally, the patient started having pain in his upper back from the tumor that was in the chest next to the vertebral body. So they gave a fairly high dose of radiation, the SBRT, to this tumor. So A and B are showing the slow progression of the tumor on the medicine. C, the column that's in the middle, is basically when they decided to give some radiation treatment to the spot that's in the back. And they gave 3 fractions of SBRT. And then D and E are showing that over time, the spot in the back that was treated responded to radiation, which is not shocking. That's what we treated. But actually, they surprisingly saw that the other spots that did not see any radiation, like the lymph nodes in the chest, the spot in the liver, as well as the multiple spots in the spleen also disappeared. So it's a combination effect between the radiation and immunotherapy, and this is something that we're still trying to understand and exploit, and we hope to have exciting results coming out of this in the future for other kinds of cancers, including prostate as well. So I think my very last parting word about radiation is it's not just about the technology, which is very important. It's also about making sure you have a doctor who knows how to use the technology. So thank you.
Thanks, Jing. So our next speaker is Dr. Jonathan Wright, who is a urologist, a surgeon in the Department of Urology at the University of Washington, and also has an appointment here at Fred Hutchinson. In addition to actually surgically treating men with prostate cancer, he has a very active research interest in understanding issues related to prevention and certainly preventing progression. So he's going to talk a bit about exercise in that role. Jonathan?
Thank you, Pete, and good morning, everyone. So we've heard a bit about the evolution of screening, the evolution of radiation therapy. You're going to hear later about the evolution of our treatments, and I get to deal with this evolution. Obesity has certainly become an epidemic in our country, and it's becoming an epidemic worldwide as well. And the question is, what does that have to do with prostate cancer? Well, it has a lot to do with prostate cancer. We know, and this is pooled data from upwards of 1 million patients from different studies, that obesity is associated with prostate cancer mortality. So BMI is your body mass index. It's a ratio of your weight and your height. Normal weight is a BMI less than 25. Overweight is 25 to 30. Obese is greater than 30, and so on, very obese above 35. These pooled data show that among men with prostate cancer, for every 5-point increase, so going from normal weight to overweight, 20% increased risk in prostate cancer-specific mortality. You go from overweight to obese, another 20% increase in prostate cancer-specific mortality. Certainly, obesity leads to non-prostate cancer death, cardiovascular disease, et cetera, but it also is driving the cancer. And just to highlight this, we contributed to some of this huge work. Dr. Stanford here was one of the authors on this, on a paper looking at our own experience with obesity and prostate cancer progression. We even know, not just looking at mortality, but also we heard earlier about the importance of active surveillance and reserving treatment for those patients who are most likely to have adverse pathology. This is a study where they took men with low-risk disease on active surveillance. They all had a second confirmatory biopsy, trying to get rid of the idea that the first one just sampled poorly. And then they followed them for several years. And these patients, for those men who are on active surveillance, know you undergo sequential biopsies. And what this bottom line shows here, the green line, this is looking at men that were obese on active surveillance. And they were more likely, over time, to have more aggressive prostate cancer found on surveillance. This is a complex picture, but what it's looking at, if we go from the active surveillance now to the active treatment, men who have prostate cancer undergo prostatectomy. Those who gain weight after prostatectomy, that's this line. Weight change, percentage, that's the hazard ratio, the risk of recurrence goes up. Even after prostatectomy, gaining weight, increased risk of prostate cancer recurrence. This curve going down below 1 is those patients that were losing weight after surgery, going from obese to overweight down to normal weight. You can impact the disease progression or action by being active in your own life. The problem is it's not easy to lose weight, as all of us, myself included, know. This is from another local effort. This is data from the past prostate active surveillance study, the Canary protocol, the Canary supported study. This is about to be published. And there's a lot going on here, But the thing to focus on is these big green bars in here. These are the percentage of people at 6 months and 12 months, normal weight, overweight, and obese, on active surveillance, who basically stayed the exact same weight. Not many people are gaining or losing weight. And certainly we're seeing these patients and we're telling them, hey, improve your activity, improve your diet. But we don't do a very good job of impacting it. I think people need more direction. I know we all do. And this may be part of the problem. We tell them, go exercise. It's a great picture. So the American Cancer Society has clear recommendations for us about what we should do. Be more active, and they give us guidelines. Aim to exercise at least 150 minutes per week. That's a half hour 5 times a week, 22 minutes every day of the week. Include a little strength activity in there too, strength building. Once we get past 40, we start losing some of our muscle mass. Certainly patients that are on androgen deprivation therapy impacts our bone strength, impacts our muscle mass. We lose it as well. Even more important in those groups to add on some activity as well. And we want to get to moderate levels of activity for the 150 minutes per week. And I'm going to go through some different data that have shown just how exercise, because as we said, we don't have a lot on diet today because Dr. Neuhauser's not here, and I'm focusing on the exercise, but showing how exercise can have a significant impact in our prostate cancer. These are 2 large studies, 50,000 men, 75,000 men. These men actually didn't have prostate cancer when they enrolled. But those that were getting up to a moderate level of activity per week had a 70% reduction in developing advanced prostate cancer, a 30% risk of developing aggressive prostate cancer. So getting up to a moderate and vigorous activity can decrease the risk of prostate cancer development. But we are also starting to see that exercise in those with prostate cancer can reduce the risk of progression. 1,500 men localized cancer, just walking more than 3 hours a week. Okay, that's 180 minutes. That's pretty close to the 150 at a brisk pace. More than 3 miles per hour. Significant reduction in the risk, 57% lower risk of disease progression compared to those who walk at an easy pace for less than 3 hours a week. We aren't talking about doing wind sprints and getting out there and running marathons. You don't have to do that. Another study, almost 3,000 men, same thing. Walking at a brisk pace, more than 3 miles an hour, associated with lower all-cause mortality, not surprising, but also lower risk of prostate cancer mortality. And if you can get up to even vigorous, we're talking about a 61% lower risk in prostate cancer-specific death. It was just presented at the American Association for Cancer Research last week. More data, another study showing the same thing. Increase moderate exercise, lower risk of cancer progression and death. And there are other benefits to exercise in prostate cancer. This is not that important. This is basically meta-analyses, okay, where they pool a bunch of studies together to see what the effect is when they bring all these studies together. These are all studies brought together of men with prostate cancer. They all show improvement, cancer fatigue, overall improvement in quality of life, sexual function, upper body strength, lower body strength, aerobic fitness. So not only are we improving the disease, hopefully, but we're also improving quality of life. And that's obviously exceedingly important when we're talking about quality and quantity of life with prostate cancer and other cancers as well. So what is moderate activity? People ask this all the time. And I actually took this from the U.S. Department of Health and Human Services online. The CDC put this out. They define light exercise, moderate exercise, and vigorous exercise. You can read all these. Brisk walking, 3 to 4.5, 5 miles an hour. Vigorous is walking or running more than 5 miles an hour. Yoga counts, calisthenics. Play doubles, you get moderate activity for tennis, singles. For vigorous activity. I think for the parents and the grandparents in the room, walking while pushing a child in a stroller is moderate. And I really like this, and I took this verbatim. Handling uncooperative young children counts as moderate exercise. So keep that in mind. So chasing, dressing, lifting into car seats. So help out your kids with your grandkids, and you'll actually improve yourself too. So it won't help your sanity, but it will help your prostate cancer. So how does obesity drive prostate cancer? Well, we know obesity does a ton of different things. Actually, you can look at this. There's hormonal changes. We know about the roles of hormones in prostate cancer. Obesity leads to a state of chronic inflammation, and chronic inflammation also drives cancer. IL-6 goes up, C-reactive protein, all these things that we know are worse for cancer, or better for cancer, worse for us. Adipokines, people have heard about leptin, adiponectin. Leptin goes up with obesity, adiponectin goes down. And this whole concept of insulin resistance, having high sugars in your body, having high levels of glucose, altering the levels of insulin growth factor, IGF-1, and hyperinsulinemia also comes with obesity. And exercise has been shown in various studies in various cancers to act against almost every single one of those areas. It lowers your sugars. It improves your insulin sensitivity. It gives you a better adipokine levels. The leptins and adiponectins go in the right direction. It reduces systemic inflammation. And what's impressive, you do a quick, 30-minute moderate and vigorous activity, and the inflammation level changes you see are pretty dramatic. It reduces oxidative stress, something called AMP kinase, which is very important in anti-cancer. That goes up. This is really fascinating work. This was published just about 2 years ago. They took men, and they took half the men and they put them on a bike and had them go vigorously for about for an hour. And they took another group and had them just sit for that same hour. They drew blood from both of those groups. They then took cancer cell lines, these LNCAP cell lines, and they put those cell lines into the serum, the blood of these patients that exercised and didn't. And those that had exercised had a 30% reduction in the growth of those tumors in the dish. They then took some of those tumors and implanted them into mice. And they found that although the tumors developed in both of the mice, they developed slower in those that had that 1 hour of exercise. Something's going on in the blood, and it's probably one of these things. What we want to do is help understand what is that mechanism. How can we figure it out? Because then we can augment not only whatever we do for an intervention, but also potentially target that area as well. And so we're doing a couple of studies that we're leading and participating in here at the Hutch, the UW, and the SCCA. One of them is called PALS, the Prostate Active Lifestyle Study. This study is targeted toward men on active surveillance with our goal of trying to understand how obesity affects cancer progression, and also looking at other features, quality of life, et cetera. So the target population, we're looking for over 200 men on active surveillance. We're probably going to start enrolling patients early this summer, overweight, obese men on active surveillance. We're going to take them and randomize them to two groups. One will be just your general recommendations about diet and exercise, the goal getting up to 150 minutes a week of moderate to vigorous activity. And the other group we're going to have in the prevention center here, a 6-month intervention with a nutritionist and an exercise physiologist. And we're basing the intervention on what's called the Diabetes Prevention Program. It's actually very simple. It truly is just getting you to that basic exercise level and helping you how to eat smarter. And what's exciting is that patients can lose 7 to 10% of their body weight and keep this weight off for up to 10 years. 10-year data has shown that because this becomes part of your life. It's not a fad diet that you can do for 6 months and can't do it and can't keep doing it. We need to make a change for the rest of your life, and this type of intervention can do that. And then because men on active surveillance undergo surveillance biopsies, we'll be able to look at both their blood changes and also their tissue level changes as well. They're going to do questionnaires. We're going to have them, so we'll be able to look at quality of life, and we'll also look at changes in the cancer itself. And it's exciting. This is such a group effort, except for the radiation oncologist, Dr. Zeng, because we're not trying to treat these patients actively, but with surgery or radiation. Everybody else in this first group is a part of this study, a co-investigator on this study. And this just shows a schematic, randomizing patients to one of the two treatments. The other one that we're participating with, is funded by Movember. So Movember is the group that promotes growing mustaches during Movember, to raise money for prostate cancer. If you didn't grow a mustache last year, start this year. They raised over $100 million worldwide for prostate cancer research. They have given money back. We are a part of several different Movember-funded initiatives. I know several in this front row have led studies with Movember. This, we're going to look at exercise in men with advanced prostate cancer, metastatic, progressing, castrate-resistant prostate cancer. The goal, we are one of, I think it's 15 or 20 international sites. There's only 4 or 5 U.S. sites, and we are one of those sites. The primary outcome is going to be looking at overall survival, because this is a more advanced state, but we'll also have other outcomes as well, looking at drawing serum. They're actually doing muscle biopsies in a couple of the patients to look at those kind of changes too. So very exciting. We're looking at both exercise in the early stage and also in the advanced stage. Active research going on here to understand this mechanism that we know exists and trying to define it. And I'll leave you again, 150 minutes, moderate to vigorous exercise a week. Do some strength training. Thanks so much.
Thanks, Jonathan.